In terms of clinical management, supportive care is what saves lives. This starts with immediate isolation and the notification of infection prevention and public health teams. Patients require aggressive oral or intravenous rehydration. You must monitor potassium, sodium, renal function, glucose, and lactate whenever these tests are available. It is also essential to treat co-infections and mimicking conditions, such as malaria, bacterial sepsis, typhoid, and pregnancy-related complications. For symptom control, use antiemetics, analgesics, and antipyretics. Avoid any unsafe procedures and minimize the use of sharps. Where resources allow, be prepared to escalate care to include oxygen therapy, vasopressors, blood products, or organ support. Infection prevention and control is vital to stop the amplification of the virus in healthcare settings. Triage patients early by screening for fever, gastrointestinal symptoms, and exposure history. Move any suspected cases immediately to a designated isolation area. Protecting the staff is paramount. This requires rigorous training on personal protective equipment, including observed donning and doffing procedures. Staff must avoid any unprotected exposure to blood, vomit, stool, or corpses. Finally, break the chains of transmission through active contact tracing and 21-day monitoring, as well as implementing safe burial practices and engaging closely with the community. Remember that both previous and current outbreaks of this virus have involved infections and deaths among healthcare workers. To understand why the 2026 outbreak is different, let us compare it to recent events. The Zaire Ebola virus outbreak in the Democratic Republic of the Congo from 2018 to 2020 involved over 3,470 cases with a case fatality rate of around 66%. Crucially, it had an approved vaccine, Ervebo, and approved therapeutics, Inmazeb and Ibanga, and a public health emergency of international concern was declared. The outbreak occurred in a conflict zone. The Sudan Ebola virus outbreak in Uganda in 2022 had 164 cases with a case fatality rate of about 47%. There were no approved vaccines or therapeutics. No international emergency was declared, and there was no major conflict context. Now, the current Bundibugyo outbreak involves over 246 suspected cases in Ituri and 2 confirmed cases in Kampala, with an uncertain case fatality rate, though 80 suspected deaths have been reported. Like the Sudan outbreak, there are no approved vaccines or therapeutics. However, an international emergency has been declared, and the response is complicated by conflict, high mobility, and limited tools specific to this virus. The public health response priorities are clearly defined. Surveillance must focus on active case finding, community reporting of deaths, contact tracing, and 21-day monitoring. Laboratories need decentralized testing and sequencing for the Bundibugyo virus, along with strict quality assurance for assays that do not target the Zaire species. Clinical care requires establishing treatment centers near the epicenter, providing optimized supportive care and ensuring safe referral pathways. Infection prevention and control efforts must emphasize triage, training on personal protective equipment, mapping of health facilities, and deploying safe burial teams. Risk communication is critical, involving community leaders to build trust, responding to misinformation, and promoting culturally safe practices. Finally, regarding borders and travel, the focus is on exit screening and providing advice, rather than implementing border closures or broad restrictions on travel and trade. This outbreak has highlighted several critical knowledge gaps. The natural reservoir for the Bundibugyo virus remains incompletely defined, and the pathways for spillover into human populations are uncertain. Clinical data are limited to small prior outbreaks, meaning prognostic markers and long-term sequelae are not yet well characterized. The diagnostic performance of assays across non-Zaire Ebola viruses needs wider validation and increased local capacity. With no licensed vaccine or therapeutic for this specific virus, experimental pan-Ebola virus candidates urgently need human data and clear pathways for deployment. Finally, determining how to conduct ethically rigorous clinical trials during unstable outbreaks remains a significant practical challenge. Here are the key takeaways. First, Bundibugyo virus disease is a type of Ebola disease, but it is not the Zaire Ebola virus disease. Second, the current outbreak is a public health emergency of international concern due to its international spread, uncertain extent, and the complex nature of the response. Third, the clinical syndrome begins nonspecifically. While hemorrhage is a clue to severity, it is not required for a diagnosis. Fourth, for any suspected cases, you must isolate the patient, protect the staff, notify public health authorities, and test using diagnostics that are aware of the specific species. Finally, because there is no approved vaccine or therapeutic specific to the Bundibugyo virus, optimized supportive care and rigorous infection prevention and control are the central pillars of the response. This concludes the lecture. The information presented was drawn from the World Health Organization's declarations and updates from May 16th and 17th, 2026, as well as the Centers for Disease Control and Prevention's Basics on Ebola Disease, updated on May 15th, 2026. Thank you for your attention.